Over the period of the next spending review, and we now know what that review will comprise, the settlement for the NHS will be virtually static in real terms. A cash increase of a little over 2% will generate around 0.4% over the next 3 years. Such real growth is substantially below anything experienced in the past, but is also in the context of public expenditure, which is reducing by far more than in the past. Additionally, the government is requiring the health service to generate efficiency improvements of about 4 to 5% a year over the next 3 years, saving a total of around £20 billion. These funds will be used to move the service forward in real terms, paying for more staff, hospitals, etc. Also over this period, management costs are to be reduced by 45%, a huge slice of that particular expenditure heading. So the context for any review of the health service in England has to be a bleak one financially. Within this picture, the NHS White Paper now envisages devolving the commissioning function to GP consortia who will take on responsibility for commissioning local healthcare on behalf of their patients. They'll have real budgets to commission services, and as a consequence of this, primary care trusts and strategic health authorities will be abolished and a new independent NHS commissioning board created. The performance targets in the health service at present, such as waiting times, will be replaced with a set of national outcome goals based on clinical evidence, which the public can use to judge the performance of the NHS. This same outcomes framework will be used to hold the new NHS Commissioning Board to account. Critically, the White Paper proposes extending choice to any willing provider, rather than the NHS being the preferred provider. This will involve all NHS trusts being or becoming part of foundation trusts. This will create a new market in healthcare, building on the pressure-provider split, which we've come used to, and creating a potentially competitive environment around secondary care and community services. This market will be regulated by Monitor, which currently deals with NHS Foundation Trusts, which will act as an economic regulator but also have a duty to promote competition. Its other roles may be strategic and have yet to be firmly decided. The White Paper proposes also that training and education should be devolved, giving employers greater autonomy and accountability for planning and developing the workforce. It envisages greater professional ownership of education and training, and that all providers of healthcare services will pay to meet the costs of education and training, the mechanism for which at this stage is not yet known. For the BMA, critically, the White Paper permits new arrangements for setting pay with greater local determination. As part of this process, it will encourage NHS providers to become social enterprises. The public health function will move to local authorities and a new national public health service. The budget for public health will be ring-fenced and protected, particularly the local authority part, but at this stage, the precise operation of the two public health spheres is not yet decided upon. All this will happen very rapidly. The NHS Commissioning Board will run live from April 2012, and GP consortia will be in place in shadow form in the financial year 2011-12. GP consortia will be set up in full by 2013. All NHS trusts are to become, or become part of, Foundation Trusts by 2014. So what to make of all this? Well, as we saw at the beginning, what we sought from NHS reform was less political control, clinically led commissioning, a strengthened public health function, the ability to integrate and define new pathways of delivering healthcare, and a central role for education and training in local health economies. All these, on the face of it, the White Paper seems to deliver. I say on the face of it because, as yet, we still don't know a great deal of the detail. What we didn't ask for, and what the White Paper majors on, is a competitive environment for healthcare delivery. We did not ask for the incursion of the private sector to the extent that the White Paper envisages, although we did concede a limited role for it, where the NHS could not provide a service or where a new service was coming to being and where the private sector felt it could deliver it more efficiently and cost-effectively. We certainly did not ask for local pay and workforce determination, which we consider will undermine the whole ethos of the National Health Service. We still don't know a great deal about the new NHS environment envisaged by the White Paper proposals. We do not know how the public health service will be funded. Critically, we don't know the geography of the new NHS, with PCTs and SHAs abolished. And although we expect weighted capitation to be the bulk of the mechanism for allocating resources to consortia, we don't yet know the precise formula and how it will take into account the variation in consortia populations. We don't know what will happen to national pay and contracts. We know that more will be devolved to a local level, but we don't know whether or not there will still be a default national contract, although we've been told that the GP contract will be a single contract and will at some stage be renegotiated. The functions of the abolished tiers of management will have to go somewhere in the health service, and as yet we don't know precisely where all of them will go. Perhaps most importantly, we don't know who will be responsible for strategy in the new NHS. It seems probable that local authorities will be involved, monitor, and the consortia themselves, but the precise operation of the strategic function is not yet known.